Greetings from India Medical Association, and the new team IMA has taken over a week back, and I introduce to you my national president. I am Dr. K.K. Aggarwal, I am the Honorary Secretary General, and our national president is leading the Team India concept. IMA has 1700 branches. Only yesterday, officially, Telangana branch has been gone. It took time to clear it. We signed it yesterday in Telangana branch. So now we have 30 state branches. And we have 2.5 lakh membership.
2.5 lakh
doctors membership. And we connect to around 4 lakh doctors every day through various resources, connection. So we reach 4 lakh doctors. 2.5 lakh doctors are our paid members. The rest of them are we connected to them. And we have a 1 lakh medical students who are under our forum, which is extra. Our national president is a neurosurgeon. He is a Padma Shri awardee, and he is a very respectable national figure in our country. And because we have taken over only a week back, specifically I have called him here for interacting with all of you.
Welcome you all for this press conference, and I thank you for coming for this, and very happy and prosperous new year to all of you. IMA, as you know, is the largest association of doctors all over the world. This number of doctors, no other medical association has. So we are very strong. We have 15,000 odd branches all over India, and we have 2.5 lakhs doctors in our fold. Although the total doctor community number will be around 5 lakhs, the good number is our members of Indian Medical Association. And we have our own views on health and health policy. And to tell you about an overview of the health scenario in our country, I must say that we are not very happy with our own performance and the health sector performance. Because if you take even agriculture, we are self-sufficient in agriculture. We are producing enough food to feed all the mouths. The distribution system may be faulty. And IT sector, we are far ahead. And space technology, we are far ahead. Economically also, our performance is very good. But health sector, we have areas of achievements, but uniformly, I must say that we have not been able to provide the type of healthcare that we should do as a big nation. There are areas of excellences, but there are areas where there is no reach at all. At least in some remote villages, our own citizens are born and die without seeing a doctor or even a health worker. They are born at home. When they are illness, they don't have access to health care, and even when they die, they don't get the. So that stage definitely has to change. It could be the fault of the administration, but it also is our fault as health professionals. To lead this area is our responsibility. Our social responsibility may have failed, at least to some extent. Of course, we have been time and again intervening as far as the health policy is concerned, but our voice is not so far heard well. That is what I think. So we are here to again assert ourselves to see that the public health is delivered the way it should be, and we request your cooperation to project our views. Of course, our views we definitely can debate, but ultimately we can convince you that what we stand is for public health more than anything else. So that is my ardent request to you to support our views if you agree on that, and see that the situation changes. It is high time that it should change. Because we don't have, what has happened in Bilaspur, a camp where 130 people die, it's not a light thing. It has to be taken very seriously by any person with a consciousness. And here again, government attempt is immediately to find a scapegoat in a doctor. A doctor who has been over enthusiastic in doing this procedure. But the key factor or the fault is not addressed, and no corrective steps is being taken. Because a standard protocol has to be followed. When a camp is to be done, what are the minimum things it should be there? So if these are not followed, such pitfalls can again and again happen. So we had to address to the real problem rather than finding a scapegoat in a doctor who is a little over enthusiastic. So such similar examples, hundreds are there. So that is basically what I feel. Our health delivery system has to change. We have come out with a 3-tier system. You have primary health center, district hospital, and medical colleges and all. But that system is not followed. Now any person can approach any consultant and seek medical help. So what happens? The consultants or the center of excellence areas are overworked. So much so, quality work they are not able to do. A headache or a abdominal pain, which a general practitioner can sort out and solve, he comes to a gastroenterologist or a neurologist. And his precious time in handling very serious cases are lost. So a re-establishment of a 3-tier system has to be there. What is the role of a general practitioner? It has never been defined in the health policy. So much so, a MBBS doctor don't feel confident to go to a rural area and do a practice of his own, a practice of a family physician. Because the government doesn't define what is the role of a family physician or a MBBS doctor. So these are the gross deficiencies in our health policy. But we are glad that the government is going to have a new health policy. It is in the public domain, and we are definitely working on it, and we will be coming out with our own suggestions within 30 days or so. So there we are working. Another area is when the 60% of healthcare is handled by the private sector, in the health policy, there is no inclusion of the private sector, which is delivering 60% of the healthcare. Today we had a meeting with the government on the TB control program. So the government or even the officials, the policy is that even in the private sector, we should have centers to give free drugs for TB control and to supervise it. While the enthusiasm of the government sector or the district TB officer to implement it or to complement IMA's effort is not there. That is because the policy is not defined. What is the role of the private sector? How the resources, underutilized resources, unutilized resources in the private, it is abundantly there. Even the best of the hospital in the private sector, you find that there is still, say, 30% or 40% underutilized or unutilized resources are there, both in terms of manpower and equipment and laboratory facilities. This can definitely be harnessed by the government. It is not defined in the health policy. So, role of the family physician is not defined. The role of the private sector, which is a dominant sector in healthcare delivery in our country, is not defined. So unless these are defined and their place is emphasized, we will still be groping in the darkness. Government is only able to spend 20% of the expenditure. 80% of the expenditure is off the pocket expenditure by each individual. What the government could do all these years? We are saying that now only 1.5% of the GDP is spent on health. We are saying that at least 8% should be spent. this 8% sort of generation need not be directly by the government. But this 8% government can do by utilizing the resources in the private sector. And also charging some cess on, say, vehicle tax, alcohol, tobacco. A health cess has to be charged. So resource mobilization is not very difficult. Government is planning to have a great role for the health insurance sector, which we feel is not in the correct direction. Because United States have a system where it is entirely private sector monitored. And the insurance sector is the one which is delivering the healthcare in that country. Even there, in spite of the resources and economic power they have, 40% of the people, the healthcare is either delayed or denied, even in that country. Just because it is all driven by the private, health insurance sector. But we should have a combination of strong government support plus adequate and effective utilization of the private sector. And that is what we are demanding. Private sector, how you utilize, it's not a great thing or a difficult thing. You can have a system of empanelment where you fix a rate for each procedure. And let the private hospital to a citizen who can afford charge at the level they are doing now. But to give the facility to the public and the poor, let the government and the private sector sit together and fix a rate which will be affordable to the government and also the private institutions. So a system of empanelment by which you fix a rate and the underutilized and unutilized resources in the private sector can be tapped. So much so, health care can be made much more affordable to the public. Now 80% they are shelling out from their pocket. And every year the statistics show that 4% of our population is pushed down the poverty line just because of expenditure on health. It is not a small thing. And generally when you look at it, 40% of the people spend more than what they earn annually or per month on health alone. So what is the money left for housing, food, education and things like that? So that's a scenario, if you look at it in terms of affordability, it is horrifying. There are solutions. If you sit down and think and come out, we can definitely help the government to come out with a solution in the lines that I am telling you now. Utilizing the resources in the private sector, defining their role, even national disease control programs, even though IMA is volunteering, IMA's resources and manpower and organization capacity is not utilized properly by the government. It can be used, it can be tapped. Because we are the leaders of the profession. And over the years we have studied these problems and we know better what is the need, what the society wants, and we can give suggestions. Medical education, again, if you look at it, we have a syllabi, the whole syllabi and curriculum, if you look at it, it was formulated in 1997. After that, there's not been a complete revision of the curriculum or syllabi for the medical students. So a medical student who is entering the medical colleges today, when he comes out, he is learning a syllabi and curriculum which is 22 years old. And how is he going to address the present day diseases, the present day problems, and what is the motivation and orientation a medical student is given to serve in a peripheral area or rural area. These processes are not incorporated in the medical education process. So complete revamping of the medical education to equip him to serve the rural society with motivation has to be there in the medical curriculum. And we are there to give suggestions because IMA is a body where right from a general practitioner to even Director of Medical Education or even Vice Chancellor, all are members. So we have enough and more of resources with us. And we have a think tank which can definitely give us a lot of. But only thing is the government has to give proper importance to what IMA is saying. Many a time, the laws are made in the health sector without consulting IMA. And after it comes, then we have to struggle and we have to protest ourselves, we have to show our visibility to prevent certain things we strongly believe is not best for the health of the public. Even the Clinical Establishment Act which has come, the one provision in the Act is at the district level, 3 persons decide which are the hospitals to be registered. And among that, one is a police officer. What is the role of a police officer in deciding whether a hospital should be registered or not? We cannot just find out a good reason for including them. So there is rules and regulations are formed. And this Clinical Establishment Act, one purpose of the Act is to have a minimum standard in health. But the rules and bylaws that are incorporated in the Act is only going to sort of re-establish the license charge and not promote a uniform standard. This you can do only by a system of accreditation process and not through these sort of regulations. IMA is for uniform standards. IMA wants a minimum healthcare standard is retained and maintained, and every citizen gets that. And the solution is not the way the Clinical Establishment Act has been framed now. We have suggested changes to convert it into an accreditation body with input from IMA and other professional groups, so that by a process of encouragement and incentive, it can be done. A hospital which is to be overnight converted into an institution where the minimum standards are to be maintained, lot of investment, lot of manpower has to come in. There is no clause which promotes these things in the Clinical Establishment Act. There has to be a promotional clause, say some funding or loan or something like that, so that this can be done. Without that, if you say that it has to be done and a police officer is put in the committee to enforce it, to threaten the doctor to have, by threatening, do we think a minimum standard can be achieved? So such thoughtless clauses are there in many of the bills that come. So we have given our suggestions, but we need your help to see that things are put in the right perspective and things do happen. Another major objection we have is on mixopathy. Bridge courses between different systems of medicine. We don't know how far it is going to encourage or facilitate or improve healthcare delivery. Each system works on a different principle. Homeopathy says that when you go on diluting, its efficiency increases. Modern medicine says that when you go on diluting, its efficiency decreases. We say that some of the disease processes are due to infection. Homeopathy says that there is no infection. It is all changes in the body constitution things. So the contradictory principles are there. Of course, each system has its own usefulness. In certain areas, it can be used. But you define where each system can be useful. We are not against promoting other systems, because we don't know what other systems have. But let government promote it. Let them come up. But it's not by mixing it. Not by allowing a homeopath to write modern medical drugs. Not by allowing a Ayurveda doctor to write modern medical drugs. Let those systems develop, do research and grow and serve the health needs of the community. It has all these systems has its own importance. We don't deny it. But let them develop in their own system. Let government give encouragement to develop them in their own area. But mixing of different systems, allowing modern medical doctors to practice Ayurveda or Ayurveda doctors to prescribe modern medicine, we are 10% against it. It is going to be very dangerous Even modern medical doctors, in spite of all this training, in spite of specialization, in spite of having so many CME programs, still I cannot say that we are fully competent to write drugs for every disease. But we are still in a learning process. How can a person of a different system, by a crash course of exposure for say 2 months or even 6 months, become competent to prescribe those medicines and write those medicines? That is going to be dangerous and it is going to cost lives. So we strongly believe that mixing of systems should not be there, but every system has its own scope and limitations. Let each system grow in their own perspective and serve the health needs of our society. There we are very. Now the present government has a tendency to promote Ayush. We are not against promoting Ayush. Let Ayush grow in its own way, but don't mix it with modern medicine. Let modern medicine go in its own way. Let Ayush grow in its own way. But don't mix different systems and produce more quacks. We already have a lot of quacks. Let us not systematically or with government support produce more quacks. It is going to be very dangerous to our healthcare delivery system. Then there is a deterioration in the doctor-patient relationship, public viewpoint of doctors for various reasons, as not the way we want and we expect. But here again, we are very conscious about that. To address those problems, IMA is going to have an ethics committee and a grievance cell, so that any doctor or any citizen can give a complaint to IMA. We will be periodically sitting at least once in 3 months at a national level and state level and district level, and we will try to address these problems and find a solution. And we are not here to safeguard our own doctors who do wrong things. If they do wrong things, we still take it very seriously, and the ethics committee's job is to go into those areas. And the grievance cell, lot of the doctor-patient relationship worsening is mainly because of misunderstanding. So to a large extent, we can correct the misunderstanding through the grievance cell. And also, if you really feel that something has gone wrong on the side of the doctor, we don't hesitate to take proper action in those areas also, because this has to improve. Doctor-patient relationship has to improve. So that again we will be addressing. And IMA's intervention in disease control and things like that, we have our own agenda on that. Various areas, right from sound pollution to sort of our habit-related diseases and other newer infections that are coming in, then psychiatric illnesses and addictions. All these things, through a process which is already happening in IMA, we will be strengthening those areas where we can do. Many a time, the government excuse for mixopathy is that modern medical doctors are not available in the periphery. This, as I already mentioned, one solution is let government define what is the role of a family physician or MBBS doctor. Then he will be much more interested to go to the periphery and start a practice. Second thing is that at least 14% of the primary health centers, there is no doctor. IMA is ready to use those doctors in those centers, because IMA members who are doing private practice in these areas definitely can be utilized. IMA will be facilitating agency to see that these private doctors on a contract basis, they work in areas where doctors are not able. That responsibility IMA is ready to take up. And but we don't want mixopathy. just training quacks to serve in the rural area, because rural Indians, they are not less than animals. Even for treating animals, we have a veterinary doctor who undergoes 5 years of training, proper training. Just because a person is born in a rural area, he should not be allowed to be treated by quacks or by people who are trained for 3 years or things like that. That we strongly object. These crash courses to produce more doctors, we are again objecting there. So this is our perspective, and my learned Secretary General, whom you are very familiar, he has been all along a strong health activist. He is vocal in the media, and I am fortunate that I have a very strong person as my lieutenant. We will together see that some change do occur in the health scenario. And now,
Thank you.
it is for him.
Thank you, Dr. Pillai.
In India, why goalpost has to be shifted again and again for health for all? How much blame should be apportioned to you? As you said, you are also guilty for that. And how much blame should be put on the door of the government?
Yeah.
Since he said that only national issues of national importance will be discussed, that is why this.
Yeah. See, if you look at the role of the medical associations internationally, whether British Medical Association or American Medical Association, before a health policy or a bill or law comes, the medical association is taken seriously. Their viewpoint is given enough importance. So, lot of modifications in the bill do come. So this process never happens in our country, unfortunately. We try to know existing rules and regulations and all, but it is not through a direct process. And our views are not even important, it should be given. Because the spectrum of Indian Medical Association is that right from a general practitioner to the top administrators and the best of the specialists are all members of Indian Medical. That is our advantage and that is our strength.
Recently, the Niti Ayog has been constituted into a planning commission. So will it make any difference for the health sector? Because you are not happy with the performance of the health sector so far. So what is your comment on this Niti Ayog?
What is it?
See, the planning commission has been
Planning
abolished.
commission has been renamed as.
Always. The renaming is not going to make much difference. But the process is, let the government take IMA seriously. Let them give importance to our views. Because we have the brain power and think tank to suggest changes and reforms.
Why then IMA is not being taken seriously by the government of India?
No, let me tell
Yeah.
you. मैं इसका जवाब दे देता
Mainly
हूँ.
for political reasons.
No,
But
I
you are a
think-
very strong body
No,
and you
no,
are
no,
the
yeah,
only
let me-
organization.
No, I will tell you. See, the BRHC course, that was few years ago. The government almost, Ghulam Nabi Azad period, we had objected to it strongly. And government did go ahead with that, brushing our objection. Then we had to, the practicing doctors had to come to Delhi, and one day we had to protest. So our protests and visibility, then the government heeded. And so that BRC course is now in the cold storage. But then they are trying to revive it other ways by starting bridge courses and things like that.
But what is your views about
No,
this
no.
present government?
What I'll answer you is, कि अभी तक till today the government, we cannot comment today's scenario with the previous governments. Okay, the previous governments they were taking decisions and policies without involving doctors. They used to have individual doctors as their advisors. They will call their own people who are treating them, call them and decide whatever they wanted. In our installation, Nataji came in Gujarat, and he said only one word. He said IMA is indispensable. IMA means the medical professionals' collective consciousness. And he says, as far as the current government is concerned, we will work together. That means And that's the reason they have given us the policy which has come, they've given 2 months. Yesterday there was a meeting on rural doctors retention and 40% presentation we presented. There was a discussion on generic medicines. We had a voice too, and they respected our voice. I personally feel let's not compare ourselves with the last couple of decades because the things are different today. And I think we are going to work together. And medical profession, IMA is committed for the welfare of the medical profession. And I don't think so government will oppose because they are involving us practically in every meeting. For example, in Jan Aushadhi scheme, the government is asking doctors to write generic. Okay, all of you have been, why don't you write generic, why don't you write generic, why don't you write generic? And IMA had, with the permission of the president, I represented the IMA, and we had a very strong discussion there. And our strong discussion was, I said, why do you want to force us to write a generic drug? Because if you force us to write a generic drug, what will happen? The chemist will be free to use whatever company he wants. He will only use his margins. It will not, the benefit will not go to the patient. So what was the conclusion was, now the government has a bureau called BPPI. The job of a bureau is to find out, first of all, come out with a quality control. So they say we will ensure quality control of drugs which are procured from various pharmaceutical companies, not necessarily government pharmaceutical companies, whose rate will be decided by the government, whose quality will be decided by the government. They may belong to Ranbaxy, they may belong to Zydus, they may belong to a multinational company. And these drugs will be available in every chemist under the brand of, under the name in the bracket of BPPI or Jan Aushadhi, and which will be affordable and of quality. And IMA said, why not? Why not? Because once these drugs are available, I don't have to go now to the website and find out which one is cheaper, which one is costlier. And if government can make us available cheaper and affordable drugs, there is no reason why doctors should not write about them for people who can't afford.
हेल्थ मिनिस्ट्री ने गाइडलाइन जारी की है डॉक्टर्स को कि जेनरिक दवाओं का स्पेलिंग क्लियर लिखें और बड़े अक्षरों में लिखें, साफ सुथरा। तो क्या IMA कोई ऐसा इनिशिएटिव लेने जा रहा है कि आप सारे डॉक्टर्स को कहें कि भाई दवाइयों के नाम तो स्पष्ट शब्दों में लिखें, साफ शब्दों में?
We are doing it, and KK is very much.
MCI की ये
His obsession is that.
दवाइयों के नाम कैपिटल वर्ड्स में लिखने हैं। कैपिटल वर्ड में ना लिखना MCI के कानून का उल्लंघन है। कोई उल्लंघन करता है वो एक अलग चीज है, लेकिन IMA और MCI का स्टैंड बड़ा क्लियर है। पिछली प्रेस कॉन्फ्रेंस में मैंने आपको एक एग्जांपल दिया था लेवर्टा और केवर्टा का। लेवर्टा इज लिवोसेट्राजीन जो कि जुकाम में दी जाती है, केवर्टा इज वियाग्रा। एक आदमी को लिखा था लेवर्टा, उसने खाली केवर्टा। यू कैन अंडरस्टैंड स्पेलिंग गलत होगी तो क्या होगा, यू कैन अंडरस्टैंड स्पेलिंग गलत होगी तो क्या होगा। और ये एक एग्जांपल दे रहा हूँ, ऐसे रोज होते हैं। इसलिए स्पेलिंग को अगर कोई भी डॉक्टर आपको मिलता है जो दवाई के स्पेलिंग को बोल्ड लेटर में, कैपिटल लेटर में नहीं लिख रहा, तो आप उसमें ऑब्जेक्शन उठा सकते हैं।
What is the punishment? Capital
Punishment. Punishment is if there is a complaint in Medical Council of India, and if he is writing, there is no harm, warning. If there is a harm to the patient, it entitles to an action. Action will depend upon where he goes. If he goes to the Consumer Protection Act, then he gets a compensation. If he comes to us, we issue a warning. If he doesn't improve, suspension for some time.
So this is Richa from Candice. Sir, my question is, what are the steps being taken to prevent public from Ebola? What are the plans and precautions?
Okay, Ebola IMA has a project. IMA has come out with a guideline. We have already had 2 webinars on the Ebola, and at the moment, Ebola is not a national threat. And IMA members of 2 lakh doctors are being trained to be prepared on Ebola. Next.
सर हमारी जो चिकित्सा पद्धति है सर, ये सबसे प्राचीनतम मानी जाती है और दिल्ली के पुलिस कमिश्नर कहते हैं कि विसरा जांच के लिए बाहर भेजा जाएगा, विदेशों में भेजा जाएगा। क्या
we have already issued guidelines. We have already written to the Prime Minister and to the Health Minister that it is very pathetic कि आपको सुनंदा पुष्कर के केस में विसरा सैंपल के लिए बाहर भेजा जा रहा है। अगर इस केस के अंदर में ऐसा हो रहा है तो लाखों की तादाद में मर्डर सुसाइड की तरह घोषित किए जा रहे होंगे। एंड वी हैव आस्क्ड फॉर ए फोरेंसिक लैब स्टेट ऑफ द आर्ट इन एवरी डिस्ट्रिक्ट
for poor persons, BPL and EWS category. Some reservation is done in private hospitals. They do the consultation and this treatment they prescribe, but medicines are not available to them. What is your view? Like some cancer patients, they go to Batra under EWS or BPL and they don't have the medicines. So what is the use of going to such hospitals?
No, that
And,
is
and government hospitals also don't provide the medicines.
yeah.
You should
I'll
include this in your
I'll answer your question. That every state has Arogya Nidhi schemes of Government of India. So Delhi government has a Delhi Arogya Nidhi. Unfortunately, till 6 months back, I was not aware about the rules and regulations. If I am not aware, 99% doctors are not aware. I take it for granted. Under that scheme, if you are a bona fide resident of Delhi for last 3 years and your family income is less than 3 lakhs, you are entitled for a 5 lakh medical treatment in a year and year and year and year. 100 crores of rupees Delhi government has under that Arogya Nidhi scheme, which is a fixed deposit, and 10 crores are available for disbursement. And I went through the site the last 5 years, not more than 25-50 lakhs have been disbursed because people are not availing it. People are not aware about it. People don't know where to go and how to go. So the money is available. So when you say poor people, in the last 3 months, I got 6 people got money from that. I'm helping them in applying for that. So the money is available. Money is not a shortage. People don't know how to apply, where to go.
There needs some publicity.
Regarding your hospital, which have got a free land, it's their duty. Fight for them. If anybody fights, he gets it. No, listen to me. If anybody fights, he gets. Everybody's job is कि किसी तरीके से दुत्कारो. But if you fight for your right, you get it.
How the poor can go and fight?
Why not? That's what our job is. That's what IMA is.
Batra is sending the people to AIMS and Samyang hospital.
Listen to me. IMA is one of the slogan for IMA is this year is जिसका कोई नहीं उसका IMA. Please approach us.
आप एक टोल फ्री नंबर खोल दीजिए लोग
टोल फ्री क्यों? मेरे सारे टोल फ्री नंबर आप सबको
गरीब जब तक जाएगा वो मरीज
मेरे सारे टोल फ्री नंबर आप लोग क्या बैठे हो?
आपके तो
आप मेरे टोल फ्री नंबर नो आई रिप्रेजेंट माय नेशनल प्रेसिडेंट. आप हमारे टोल फ्री नंबर हो, भेजो पेशेंट्स को.
We can do that, sir. Definitely we can do it.
We will help. Thank you very much.
Thank you for
I wonder whether you have any solutions for the problem that